So the traumatic anterior instability includes your first the Bankert and the Bankert variants. So this will be covered in the next class. So okay. Next is your capsule-related lesions. This will be covered in the second part of today's class. And third we have is your bony injuries. Okay, so bone, your glenohumeral ligaments, and your labrum together they constitute the components of the traumatic anterior instability. Okay, so all of these usually occur together, but we will be studying them separately. But if you get a case in your day-to-day reporting, you will be getting all of these injuries simultaneously and not a single isolated injury. Okay, it's very rare to get a single isolated injuries. Okay, all the three injuries will be usually occurring simultaneously. Okay, so the most important and which is the most confusing part is basically your Hill-Sachs lesion. Okay, the bony Bankert and glenoid rim will be discussing with the soft tissue Bankert lesions. We'll discuss that with that only. And these are some accessory fractures which may be seen, which includes your greater tuberosity fracture, coracoid process fracture. Okay, and then we have labral avulsions, which can lead to some osseous fragments as well. Okay, so we'll start with the Hill-Sachs lesion. Okay, uh, by far the most common joint dislocation of shoulder is the anterior dislocation in relative to the glenoid fossa. Okay, so we have the soft tissue components, which includes your labrum and your capsules, collectively called as the labro-ligamentous complex or capsulo-ligamentous complex, and the labrum. And then we have the bony injuries. Bony injuries, they are usually bipolar, as we all know. Okay, so these includes your glenoid rim fractures, which we call it as the bony Bankerts, and then we have the posterolateral humeral head impaction fractures, which we call it as the Hill-Sachs lesion. So this will be the topic of discussion in the next slides. Okay, so the anterior shoulder dislocation, it consists of a soft tissue failure, which is your labral defects, your capsule defects, along with the bipolar bony injury, which includes your Bankert lesion as well as your Hill-Sachs lesion. Okay. Now I've seen many students and even consultants, they are confused about how to measure the Hill-Sachs interval, what is actually the concept of Hill-Sachs interval, and how to measure the glenoid tract width. Okay. So we'll try to understand all of these in today's class. Okay. So first of all, you have to learn the definition of Hill-Sachs. If somebody asks you what is the Hill-Sachs lesion, so you will say, first of all, it's a traumatic impaction fracture. Okay. So this is actually an fracture which is caused because of the impaction. Impaction of what? Impaction of the posterior superior lateral humeral head along with the anterior inferior glenoid rim. Okay, so both of these they get impacted during the abduction and external rotation. Okay, so you can say if this is your glenoid and this is your humeral head. Okay, so what it does is it basically when we do the abduction, so it goes like this, and when we do the external rotation, so it goes like this. Okay, so this part, which is the posterior superior lateral part of the humeral head, it comes in contact with the anterior inferior glenoid rim. Okay, so when it gets impacted at the anterior inferior glenoid rim, then that fracture which occurs on the posterior superior lateral part of the humeral head, we call it as the Hill-Sachs lesion. Okay. Earlier, when the CT and MRI they were not available, it was it was a very underdiagnosed entity, approximately 21%. But once CT and MRI was available, the incidence jumped up to about 67 to 93%. Okay, so you will definitely get in almost all of the cases, you will get a Hill-Sachs defect. Okay, so I want whenever you are reporting a Hill-Sachs defect, there are 3 or 4 points which need to be reported about Hill-Sachs. Don't just write that there is a defect on the posterior. I've seen many reports by the residents that just there is a posterior superior defect, okay, and likely suggestive of Hill-Sachs. Okay, no objective criteria has been used. Okay, no information about whether it's an off-track lesion or an on-track lesion, because it's very important. Because whenever we have to go for the management of Hill-Sachs, the orthopedic surgeon needs to know whether it's a off-track lesion or an on-track lesion. If it's an on-track lesion, we'll just go for the labral repair. But if it's an off-track lesion, we'll also go with the bony repair as well. So the management significantly changes depending on your report, okay, whether it's an off-track or an on-track lesion. So don't just write whether just a Hill-Sachs lesion is present and just end the report. you have to justify the report, and should be the reporting should be excellent. Okay. So what happens during dislocation? I'll show you the images as well. The anterior inferior glenoid, it impacts the posterolateral superior part of the humeral head, which causes a cortical compression, which leads to the formation of a Hill-Sachs lesion. Okay. Now, the first confusion which I have seen in many consultants and residents is that they're not able to differentiate between a Hill-Sachs lesion and a normal posterolateral anatomical groove, which we see in almost all of the cases. Okay. So there are certain points. Okay, so this you will not find in most of this, not has been specified in most of the books. Okay, but I've seen it's a very common confusion. Okay, so we'll see a simple smooth groove on the posterolateral aspect, and I've seen residents labeling it as Hill-Sachs defect, not knowing that's actually a normal anatomical groove on the posterolateral aspect. Okay, so first of all, Hill-Sachs, as I told you, it's a traumatic impaction fracture, while a normal humeral posterolateral humeral groove will be a normal anatomical depression. Okay. The first major point which is differentiating between these two is its position along the long axis. Since I told you the Hill-Sachs is a superolateral impaction fracture of the humeral head, so it's more superior. Okay. So it has to be within 2 centimeter of the cephalic part of the humeral head. Okay. So let me show you this picture. So this part, so any Hill-Sachs defect will be within the 20 mm of the cephalic part of the humeral head. Okay, so below that, the Hill-Sachs will not extend. Okay, while the normal posterolateral anatomical groove will be beginning 20 mm below the cephalic part of the humeral head and may extend up to the next the junction of the head and neck of the humerus. Okay, so it's much more inferior. Now, if you move towards the angular position around the head, how do you see the angular position? So this is an axial section of the MRI of the shoulder joint. Okay. So in the axial section, what we are doing is we are dividing this humeral head. We just take an imaginary best fitting circle, okay, over the humeral head and divide it into quadrants. Okay. So give the anterior most part. This is 0 degree, and this is your 180 degrees. This is your 90, and this is your 270. So it has been seen that the angular position of the Hill-Sachs is between 170 to 260 degrees with the average midpoint in the at a value of about 210 degrees. While this is much more medially. Okay. So this is the position of Hill-Sachs. Okay. And this is the position of the anatomical group. Okay. So we'll see that it is much more lateral, and while the normal anatomical groove is much more medial. Next, there's no difference in the depth. Both can be of similar depth with an average of about 4 mm. Okay. It will be a more of a wedge-shaped cortical depression. It would be like this, but it is not always true. Okay. And obviously, it's more lateral. It's a smooth, shallow concavity. Okay. But the best differentiating point will be the distance from the cephalic part. Within the first 20 mm, Hill-Sachs. After 20 mm, it's a normal anatomical groove. Okay. So it will be seen on most proximal axial sections, at least even in the first 1 or 2 axial sections, and this will be seen below the Hill-Sachs level as the humeral head transitions into the shaft. Okay, and if you want the relation to the muscles, so it will be superior to the teres minor insertion and it will be under the teres minor path. Okay, it's a normal variant and it obviously suggests a prior anterior dislocation. Okay, so this is the first 20 mm Hill-Sachs. After that, we have the normal anatomical groove. So it's higher, traumatic, pathological, and more lateral. Okay. Okay. So this is a radiograph, a very old radiograph. Okay. So we see that this is a much more cranial section of the humeral head, and this is a much more caudal section of the humeral head. Okay. So this is within first 20 mm of the cephalic part of humeral head, and this is after 20 mm. So in the first 20 mm, we are not seeing any defect on the posterolateral aspect. But once you move downwards on the caudal sections, you see there's a smooth concavity present. Okay, not very lateral. Okay, with average arc midpoint of 180 degrees. Okay. So since this is below 20 mm, so this is not a Hill-Sachs defect. This is a normal anatomical groove. Similarly, we can see in the MRE sections as well. Okay. So again, this is a section in the top of the humeral head. So no defect here. But once you move downwards, the caudal sections, you see a smooth indentation on the posterior lateral aspect. Again, this is a normal anatomical groove. And now you see there's a defect in the cranial section itself, which is more wedge shaped. So this is actually a Hill-Sachs lesion. Okay. There's one more point which is given, that is something which is till the level of the coracoid process is the Hill-Sachs, and below the level of coracoid process is the normal anatomical group. But better to follow the objective criteria, which is within the first 20 mm and after 20 mm. Okay. Then we have a criteria for muscle insertion as well, that is above the teres minor and below the teres minor. And one is above the coracoid process or at the level of coracoid process, Hill-Sachs, and below the level of coracoid process, normal anatomical group. Okay. So let me show you in this case as well. So now we are starting from the most cranial section here. Okay. Again, this was a young male who had presented with recurrent anterior shoulder dislocations. So the MRI was performed. So this is the most cranial section. Okay. So this is your coronal oblique images. And this is your axial images. So you see, if we move downwards, so in the first one or two sections only, you are able to see a more wedge-shaped compression defect. Okay, so wedge-shaped compression defect. Okay, see the sections. So if I take this distance, obviously this will be less than 20 mm. So it's within 20 mm of the cephalic part of humeral head. Okay, more lateral. So this is definitely a Hill-Sachs lesion. Okay. Okay. So I hope I'm clear with how to differentiate between a Hill-Sachs lesion and a normal anatomical groove. Let us move downward. Okay. And now on the downward sections, what you see where the Hill-Sachs ends. Okay, so there's a smooth. Uh, my measurement is not working here. Okay, it's very simple. You just open the corner oblique images by the side. Okay. Then you take this reference point, which is the top of the humeral head. Okay, and then you see where you can see the maximum part. Suppose it's here only. Okay, and then you can measure this distance from your DICOM images. So this should be less than 20 mm. Okay, it's very simple. Okay, so as we move downward, okay, so as we are moving downward, we see a smooth depression, which is not as lateral as the Hill-Sachs defect. Okay, much more smoother. It's not a wedge-shaped defect, and we see the level. It's obviously more than 20 mm away. If you measure the distance, obviously it will be more than 20 mm. Okay, more than 20 mm away. Okay, so this is a normal posterolateral anatomical groove of the humeral head. Okay, and if you trace it more inferiorly, okay, you will see that it okay, intertwines with the uh, junction of the humeral head and neck. Okay, it will smoothly transition at this junction. Okay, so now let us move on to the pathogenesis of the Hill-Sachs lesion. Okay, so it's basically it's a bony fingerprint of an anterior dislocation. Okay, so it is not, it's actually the cause of second and after second the recurrent dislocations, but it forms after the first anterior dislocation of shoulder. Let me explain. So because of a high intensity trauma, like you did this external rotation and abduction like this, and because of that, the humeral head got dislocated anteriorly. Because of this position, we call it as the ABER position, extreme ABER position. Okay, so this is the mid ABER position. This is the neutral position, mid ABER, and this is the extreme ABER. Now, what happens is this humeral head will dislocate anteriorly because of the you did like suppose you're doing in the gym, you're doing the extreme exercise like this. Okay, and because of the excessive weight, the humeral head it slips out of the socket and you undergo the first episode of anterior dislocation. Okay. Now what happens is because of the first episode of anterior initial dislocation, the anterior rim of the glenoid it impacts the posterolateral humeral head. Okay. So depending on what is the intensity of the trauma, different grades of impaction will be there. And because of this episode, a impaction fracture is now created on the posterolateral superior aspect of the humeral head. Okay. This is the origin of the Hill-Sachs lesion. Okay. Now, because of the formation of the Hill-Sachs lesion, you will now undergo repeated anterior dislocations. So it all starts with like an initial injury, you have fallen outside hand. Again, that's an extreme ABER position. Okay. And because of the formation of Hill-Sachs and your bony banquets, which is the we call it as the bipolar lesion. Okay. You will 20 to 40% cases will be experiencing your recurrent dislocations. Okay. Now, the track over which your humeral head rotates over the glenoid fossa, we call it as the glenoid tract. Okay, we call it as the glenoid tract. Or in other words, it's a contact zone between the humeral head and glenoid surface. Like there's some contact, and then the humeral head. This is the mid ABR position. Okay, the humeral head is now rotating, and this is your extreme ABR position. Okay, so the tract or the contact zone between these all positions, uh, which we have undergone between the humeral head and glenoid surface over the glenoid fossa, we call it as the glenoid tract. Okay, so this is the end range or extreme ABR position, the first one. This is your mid range, and this is your resting position. Okay, so the dislocation occurs in your extreme ABR position when the shoulder relocates. That is your mid range ABR position, and when you perform the CT MRI, you perform it in the resting or neutral position. Okay, so timing of formation, I hope you've understood. It occurs not at the exact moment of dislocation, but shortly afterwards. Okay. Okay. So this is the position in when you are in the neutral position. So this is the location of the humeral, sorry, the Hill-Sachs lesion. Okay. So this is your Hill-Sachs lesion. Okay. These are your anterior band of IGHL, and this is the posterior band of IGHL. Again, these are both stabilizers, the passive stabilizers of the shoulder joint. This is your glenoid fossa, and this is your anterior-inferior glenoid bony defect. Okay. So during neutral position of the hand, there is no engagement of the Hill-Sachs lesion. Okay. And but when you go for this mid-range ABER position, if the Hill-Sachs interval is large enough, it will engage with this anterior-inferior glenoid band. But if the Hill-Sachs lesion is small, even in the mid ABER position, it will not engage. Okay. So the point is, in neutral position, when you are looking at the CT and MRI, we perform it in the neutral position. We do not perform it in the mid-range ABR position. Okay. So you will not see any engagement of the lesion in the neutral position. And in the mid-range ABR position, you will see only if the Hill-Sachs lesion is large enough to engage with the anterior inferior glenoid rim. But if the Hill-Sachs lesion is small, it will not engage with that. Okay. So this whole is basically your from neutral to the end or extreme ABR. This whole is your glenoid tract. Okay. Now, let us understand how the formula of, you must have heard the formula of glenoid tract width, which is 0.83 into the diameter of the glenoid width minus the glenoid rim defect. So how this 0.83 has come? So let us understand the concept behind that. So this part is basically your humeral head. This is your glenoid web. Okay. This is your rotator cuff insertion. Okay. So suppose this is the glenoid web or the glenoid fossa. This is the humeral head in the resting position. Okay. So whenever we are going to do the external rotation and your, okay, so this is the posterior superior aspect, this one, which you are not able to see. But once it undergoes your extreme ABR position, this posterior superior humeral head has now come in contact with the anterior inferior glenoid rim. Okay, again see neutral position. Now it has come in contact here. Okay, so this is how you do the movement. Okay, so whenever you're doing this movement, the tract which is being followed over the humeral head, this tract, it looks like this. Okay, this we call it as the glenoid tract. Now you have to remember that only 83% of the glenoid diameter it stays in contact with the humeral head, while the 17% does not. Okay, so whenever you're doing this movement, so only 83% of the glenoid rim it is in contact with the humeral head. The rest of the 17% is in contact with the rotator cuff insertion and not with the humeral head. So that is why the formula is 0.83. Okay, so in this is a normal glenoid fossa. So this whole 83% part extending from this point to this point, okay, is in contact with all of this part of the humeral head. Okay, correct. But whenever there is a glenoid rim defect, which is again you can say it's a bony band lesion or a glenoid rim defect. Now you have to subtract this from this 83%. Okay, so this will now not come in contact. Okay, so this is how the formula of glenoid tract width is devised. So you say that you take this whole diameter, which is D, which is the entire diameter of the glenoid, you multiplied by 0.83 because only 83% is in contact with the humeral head, and you minus the glenoid rim defect. So this is your glenoid tract width. So the glenoid tract width is actually that part of the glenoid which is in contact with the humeral head during these three movements, to which is from neutral to mid-range ABER to end-range ABER. Okay. Now the Hill-Sachs defect is obviously in on the posterior superior aspect. So this part is basically a Hill-Sachs defect. Okay. Now you have to understand that if the Hill-Sachs lesion or the impaction fracture is smaller than this glenoid tract width, okay, so this hole is the glenoid tract width, okay, and this hole is your Hill-Sachs lesion. If the Hill-Sachs lesion is basically between this glenoid tract width, then we call it as an on-track lesion or a non-engaging lesion. Okay. Suppose you are driving or you are riding a bicycle, okay, in a jungle and you remain on track. Okay. Okay. So you're remaining on track. Okay. So you will not be getting in contact with the wild animals. Okay. So you can say on track and you will not engage. If you remain on track, you will not engage. So non-engaging. But if you move out of track and you venture into the wild, you will get engaged with these wild animals. So that we call it as off track or engaging lesion. Okay. Now, there are two possibilities how this Hill-Sachs can engage. Either the Hill-Sachs can be so huge that it is going out of this glenoid tract. Okay. Means now instead of a bicycle, now you're riding a big truck. So you're getting off track. So you will start engaging these wild animals. Or you can say the wild animal here is your glenoid rim. Okay. So the Hill-Sachs lesion is so much large that it goes much more medially and then it engages this glenoid rim. Okay. Or even if the uh, Hill-Sachs lesion is small, but it is much more medially placed. Okay. So this is the location. So still now it will be engaging this glenoid rim defect. Okay. So both of these cases will be of engaging lesions or off-track lesions. Okay. So off-track, you can go either you can driving with a truck or you can take the bicycle out of the way of the. So both of them you will engage with the wild animals. Okay. So engaging lesion slash off-track. Okay. This is non-engaging on-track. Now, why this is important? Because the stability depends on and the management of the patient changes. Okay. So either the Hill sachs is so much large that it has a much more medial extent, or if even it is small but it is very medially placed, still it will engage your anterior glenoid rim. So that will make the position of the patient much more unstable in comparison to an non-engaging or an on-track lesion. Okay. So and only even a small Hill sachs can be engaging if it extends medially, and a large but a lateral HSL can remain non-engaging as well, depending on whether it has crossed that medial extent or not. Okay. So important, it is engagement is positional as well as dimensional. So important. So large HSL with a medial extent engaging, but if it's lateral and no medial extent, then it will be non-engaging. Small HSL having medial extent, again engaging, and if it's lateral and no medial extent, again it will be non-engaging. Okay, so both large HSL and non-HSL. Okay, so first you have understood why the Hill sachs is formed. Okay, that is because of the first episode of anterior dislocation. Now the Hill sachs which is formed will depend on what type of trauma and what degree of trauma you have suffered. If it's a high degree of trauma, you will get a high Hill sachs lesion. If it's a small degree of trauma, you will get a small Hill sachs lesion. Now the Hill sachs lesions which are formed, they can be on track and can be off track, both. Okay, so we have talked about the uh, glenoid track. I told you this is a track along which the humeral head, it basically uh, remains in the contact zone with the glenoid fossa whenever you're doing these three positions. One is your neutral, okay, neutral, mid-range ABER, extreme ABER. Next, okay, I told you only 83% of the glenoid uh, fossa, it remains in contact with the humeral head during this position. Okay, so this part is actually redundant. This is of no use to us. You can forget this part. Okay, so we need only 83%. Now, the 83% part of the inferior glenoid part or inferior glenoid rim, it can have a bony deficiency. Why? Because of the first impaction, because of the anterior dislocation episode, first anterior dislocation episode, which occurred, okay, which produced this glenoid, anterior inferior glenoid rim deficiency, as well as your Hill sachs. Okay, so these are bipolar lesions. These are seen in almost most of the cases. Okay, now this part is the glenoid tract width. So this is your anterior inferior glenoid rim defect, and this is your Hill sachs lesion. Now, if the Hill sachs lesion is lateral, so this is your medial part and this is your lateral part. So it is medial, and so it is basically lateral and is within the limits of the glenoid tract, means it's less than the glenoid tract. Now, what will happen is when the humerus will, uh, when we'll do these motions, the mid ABER and the end range ABER, so this Hill sachs lesion will now not come in contact with this glenoid rim defect. Okay, it will not come in contact with this glenoid rim defect. Okay, so it will bypass to the side of that. So it will be in contact with this part of the glenoid rim only. It will not come in contact with this part. Okay. But if there is recurrent impactions between your Hill sachs lesion and your glenoid defects, it will lead to more instability, more enlargement of the Hill sachs defect, and more episodes of recurrent anterior dislocations. Okay, so all will this depend on how was the first episode of anterior dislocation and how large and what location of the Hill sachs lesion was produced by that first episode of anterior dislocation. That will govern whether you will be having more anterior dislocations or not. Okay? So our job as a radiologist is to define whether the patient, whether to what is the prognosis of the patient. If it's an off-track lesion, he has to undergo a bony surgery also. Okay. If it's an on-track lesion, we'll just go with the labral repair. and no bony repair has to be done in that case. Okay. Second thing important is it doesn't depend whether it's a large HSL or a small HSL. Only what depends is the medial extent. Okay. Usually large HSL, because of the large size, they will be definitely be crossing towards the medial extent and definitely will get engaged with this glenoid rim defect. There are more chances of that, but it's not always true. Okay. Even if the large HSL, if it's at this location, it will not engage that glenoid rim defect. Okay. So engagement is not only purely, uh, you can say, numerically based. It's basically based on the location as well. Okay. So not only the size matters, but the location of the hill sacks also matters. That will govern whether it's an on-track or an off-track lesion. Okay. So remember this line: engagement is positional, not purely dimensional. Okay. The relationship between the HSL and glenoid tract, it dictates your risk of recurrence as well as the management, future management options. Now let us start with the evaluation of the hill sacks. So we'll start with the radiographs, then we'll proceed to CT, and then we'll move on to the MRI. Okay. Now radiographic evaluation is not that important. There can no objective criteria is actually defined for radiographs. Okay, whatever has been defined is for CT and for MRI, and your operative management will also uh, will depend on the CT and MRI values only. So what is the role of radiographs? It's basically for the screening. Okay. So a patient has presented to you with a recurrent traumatic shoulder, anterior shoulder dislocations. So first thing which you get obviously will be your radiographs, which you would have taken. So this basically provides a historical proof of dislocation. Okay. Why? Because I've told you the pathogenesis of Hill-Sachs. It will not, the dislocation, the first episode of dislocation does not occur because of Hill-Sachs. Hill-Sachs is formed because of the first episode of dislocation. So we have first episode of dislocation. Then we have the impaction of the posterior superior lateral part of humeral head with the anterior inferior glenoid. Then there is an impaction fracture which occurs, which is your Hill-Sachs. So it occurs after the first episode of anterior dislocation. Okay. So what it doesn't tell, it tells there's a dislocation which definitely would have occurred. So it provides a historical proof of dislocation, while the cross-sectional imaging, CT and MRI, will define its extent, implication, on-track, off-track, and everything. Okay, so it helps in triaging that which patients of uh, traumatic injuries to the shoulder require further cross-sectional imaging. Okay, so don't miss this finding on radiographs because that's the first screening investigation which you will be getting in your hospitals. Okay. The best views obviously are your striker notch view and your AP internal rotation view. Okay, let us look at some signs. Okay, there are two signs which we use on different appearances. One is your diverge sign, another one is your vertical line sign. Okay, very simple signs. Okay, sometimes they can be subtle, so you can raise a suspicion for that. But if you are sure, then you can write it. It's definitely a diagnosis for it.